Good afternoon, everyone. I am Petra Sólymos, and my PhD thesis title is Investigating Radioembolization as an Option in the Treatment of Liver Tumors. I'm a PhD student and a radiology clinician at the Medical Imaging Center. And my vision is that we will not only treat but cure liver tumors with radioembolization. And my mission is to achieve that, to determine the efficacy and the safety of the isotopes used for radioembolization. Now we have two specific goals. The first one includes a systematic review and a meta-analysis investigating the safety and the efficacy of holmium radioembolization in patients with liver tumors. And the second one is a randomized controlled trial comparing the use of holmium and yttrium isotopes in transarterial radioembolization for the treatment of liver tumors. We started our first project on September 2023. So, as you may know, liver tumors are a global health problem. However, only 30 to 50% of these tumors are suitable for definitive therapies like surgery or resection. Therefore, there is a need for local-regional treatment options. One of the local-regional treatment options is transarterial radioembolization, which uses two isotopes in the clinical use, yttrium and holmium. In this table, you can see that these isotopes have different characteristics, and holmium is a newer isotope and has some advantageous properties that yttrium does not have. Holmium is suitable for SPECT and MRI imaging, and also can be used as a scout and has a superior predictive value for intrahepatic distribution and dosimetry. There is much evidence about the use of holmium for the radioembolization of the liver tumors, but still evidence on using holmium for this purpose needs to be more comprehensive. Therefore, our aim is to define the efficacy and the safety of the holmium radioembolization. So we are interested in if transarterial radioembolization using holmium isotope a safe and effective way of transarterial treatments. Our primary outcome is tumor response, and our secondary outcomes are survival rates, toxicity, and quality of life. We conducted our systematic search in 5 databases with the following search key, and at the end of our selection, we've got 20 eligible full texts. So our primary outcome is tumor response, which we express in terms of disease control rate. Disease control rate refers to how successful we were in preventing the tumors from growing. And we can measure tumor response with two systems. The first one is the RECIST 1.1 system, which, as you can see, measures the whole tumor size, including the dead necrotic part as well. But in contrast, modified RECIST measures only the viable living part of the tumor. And that's why modified RECIST is more relevant to us. Here you can see our forest plots. Here, proportions refer to the ratio of patients whose tumors were controlled by holmium therapy. For the two systems, we have 7 and 5 studies covering nearly 100 patients in both cases. The between study heterogeneity considered high in both cases, and the reason is because these are all mixed observational trials. So according to RECIST 1.1, you can see that nearly half of the patients had their tumors under control, but according to modified RECIST, more than 90% of the patients had their tumors under control. And since we know that modified RECIST is more sensitive, it clearly indicates that holmium therapy was effective. And this suggests that holmium works for the actually clinically relevant outcome, which is the rate of the tumors we could control by this therapy. Okay, so our first secondary outcome is overall survival rate. In these plots, you can see these individual plots for our study at 3 and 6 monthly time frames. And I would like to draw your attention to the size of the diamond of the plot. And as you can see, the uncertainty increases as the follow-up time increases. And this suggests that there's a clear need for well-designed long-term follow-up trials, and we are planned to do this in our second study. Our next outcome is severe clinical adverse events, defined by the CTC-AE criteria. Here you can see that the diamond is close to 0 in almost every case, so holmium therapy was effective. Severe laboratory adverse events were also defined by CTC-AE criteria in our study, and we observed severe changes in 2 laboratory parameters. We increased the increase in the gamma-glutamyl transferase levels and the development of lymphocytopenia. And here we found something that needs to be discussed in the literature better, and we would like to investigate it in our second study as well. Here you can see that other severe laboratory adverse events were almost non-existent. So holmium therapy was safe. Our last outcomes are tumor absorbed dose and healthy liver absorbed dose. So a higher tumor absorbed dose is important because it can increase the likelihood of killing the tumor cells, but limiting the healthy liver dose is crucial to prevent radioembolization-induced liver disease and other complications. In our study, you can see that the tumor absorbed dose was almost 4 times higher than the healthy liver absorbed dose, which indicates that holmium therapy was not only effective, but it was safe because the liver tissue can handle up to 6 degrees without failure. So the strengths of our study is that it clearly answers the research question with sound methodology, and it enables a subsequent clinical trial with clearly defined parameters. The limitations of our study that we included only observational studies and the outdated technologies used in previous publications limit the applicability and generalizability. So in conclusion, holmium radioembolization can control liver tumor growth efficiently without major complications. An implication for practice is that holmium radioembolization is a good treatment option in unresectable malignant liver tumors. An implication for research is that holmium radioembolization needs to be compared with currently available treatment options such as yttrium radioembolization. Okay, so here you can see the progress of my first project. We started drafting the manuscript, and we plan to submit it in September to the following journal. Okay, so our second project is comparing the use of holmium and yttrium isotope in a transarterial radioembolization for the treatment of liver tumors, and this is going to be a randomized controlled trial. So as I mentioned before, transarterial radioembolization is one option for local regional treatments, and it has 2 isotopes in the clinical use. As you can see, these isotopes have different characteristics, but their efficacy and safety on different tumor types are not yet fully understood. So our aim is to determine if holmium has different efficacy and safety than yttrium. So now that from our meta-analysis we know that holmium is safe, we designed the randomized controlled trial with a more current patient population than our meta-analysis to compare holmium radioembolization with yttrium radioembolization, and we would like to use the same outcomes as our meta-analysis. Here you can see the eligibility criteria for our study. We would only like to include hepatocellular carcinoma patients. Here you can see the interventions of our trial. The arm A is radioembolization using holmium isotopes, and arm B is radioembolization using yttrium isotopes. Our outcomes are the same as our meta-analysis. Our primary outcome is tumor response according to modified RECIST, since it's more sensitive, at 6 months follow-up time, because we think it's more appropriate. And our secondary outcomes are basically the same, but we plan to have a longer follow-up period. So to sum up, we have 2 ongoing projects right now, and we plan to submit them in September and in November 2024. So I would like to thank you for your attention with a quote: "Man can learn nothing except by going from the known to the unknown." Thank you.
Nice presentation. Also good to have the randomized trial. Did you perform sample size calculation?
Sorry?
Did you perform sample size calculation for the second project?
Not yet.
Not yet. And
But we not did it properly, but I did it. And I calculated that 40 people would
40?
be 40?
40.
40, yeah, for both arms. But I don't know if it's right because I haven't checked it with my supervisors yet.
What will be the estimated attrition rate?
Estimated
attrition rate. That is the patients that got lost, that they are not in the end analysis.
10%.
10%? Only?
I think yes.
What is the survival rate? 6 months?
6 months?
Yeah. So it needs to be less than, it needs to be 95% plus. Otherwise, your attrition rate is not okay.
Well, we haven't really did that with the second study yet. We focused on the first one, but we have a design only for the second one.
Okay, thanks.
One more question. There are any differences regarding the original liver tumors when the tumor is originating from the liver and liver metastasis,
well,
other tumors?
In this meta-analysis, there is no difference between, because we can treat everything. I mean both the liver origin and the metastasis with radioembolization. But in our second study, we would like to only include the hepatocellular carcinoma patients to see whether holmium radioembolization has a better response. I mean, can include a better response in that than the metastatic liver tumors.